Well, it's my great pleasure now to welcome Michael Penniment. Michael, thank you so much for joining us. Can you introduce yourself and give us a sense of what you do and where you do it in the Northern Territory and South Australia?
Sure, yeah, thanks Julie. Michael Penniment, as you say, radiation oncologist, and I'm director at Royal Adelaide and also one of the founding directors up here at the Alan Walker in Darwin. I've been doing a regular clinic up here for nigh on 20 years and continue to do so.
And what I want to do is focus for most of our conversation on what you're doing at the Alan Walker to close the gap and improve the life expectancy and the quality of life for Aboriginal people who've been treated for cancer. But just for the uninitiated, can you give us a sense of the scale of the problem when it comes to the different life expectancy and quality of life issues for Aboriginal people with cancer, particularly up north?
Well, I think that the couple of things that sort of bring it home quickest is that there's a significant excess death rate. In other words, Indigenous patients with the same cancer at the same age, same stage of their life are more likely to die from the same cancer than a non-Indigenous person. Overlay that with the fact that that also applies to all Australians that are away from a major centre in terms of country and remote. And so you put those two things together in the territory and you've got the issue of there's clearly access to treatment, there's the distance, there's cultural issues, and there's also lifestyle issues in terms of some of the cancers that are most affected up here are lung, head and neck, and ones that we know have a relationship to consumption of alcohol and cigarettes. And so really the problem ranges all the way through to education of what causes cancers and hence prevention, picking up cancers at an early stage, right through to treatment, and then ultimately after treatment, it's how do you follow people up to make sure that their cancer's cured and that whatever the side effects of the treatment, that they've been fixed.
Look, I just want to give people a quick visual of what you've just said. This is from Cancer Council Northern Territory, and it shows that if it's dark red, it's excess deaths from all cancers, and people can see there that up north, and you're in the Alan Walker's at the Royal Darwin Hospital, it's tremendously red. And when you go to head and neck, which you've mentioned, which I'm always keen to highlight because I've had it myself, again, excess deaths from head and neck cancer up there, they're massive. That red means it's the highest level of excess deaths. So I want to focus on what you're doing at Alan Walker. What are you doing there that is making a difference to help both assist Aboriginal people to attend a full course of treatment and also to get some support in that rehabilitation or recovery period?
I think legitimately I can speak for our staff that the first thing we've done is that we really care and we really see it's a problem and we try hard. And that sounds pretty simple, but it's an extra layer to reading a report and going, oh, there's a problem. We should do another report to work out what we need to do to fix it. Certainly up here, there's an awful lot of patients that just whenever there's something that might improve things, then they do it. The first thing we did was just getting the federal government and building the cancer centre sort of over 10 years ago now. The reports prior to the Alan Walker starting suggested that approximately 22% of patients with cancer were getting radiotherapy. And within sort of 8 or 9 years of operations, we've more than doubled that to 48%.
And why is that important?
That's important for a whole lot of reasons. The WHO suggested that of all patients with cancer, something like 48 to 50% of patients would benefit from radiotherapy. So not every cancer, there's certain blood-borne cancers and various others that you wouldn't give radiotherapy, but basically about half the patients with cancer would benefit from radiotherapy.
And so, Michael, if you were going to sum up what difference it's made for Aboriginal cancer patients that you've now got the Alan Walker Cancer Centre in Darwin, and you have staff that really care, what impact has that had on completion of treatment and, I guess, increased survival?
Yeah, well, absolutely. I think that the message has gone back to communities, and it's oral history is important, and there's nothing more important than a community elder who's gone to Darwin, The community might not have seen the person for maybe a few weeks, but they've come back well, and they've been cured. And that we're really over the 10 years starting to see that oral history come through, where we've got so many Indigenous supporters to say radiotherapy is pretty straightforward. Maybe my chest area got a little bit irritated, it all got better, I'm cured. We're starting to, so the retention rate in terms of the percentage of patients that come and have treatment and have the full course has gone up over the last couple of years from still fairly high in the sort of 80% to really in the very high 90s. And what we want to do, because I think in my journey over the last 20 years, there's also there's an attitude amongst health professionals of, rather than having that discussion and customising the treatment for the person, there's assumptions and patronism in terms of, I don't know if he'll come up for his treatment. I don't know, let's give them, instead of giving 30 treatments for cure, let's just do 5 because he might not finish. Whereas I think now we're dispelling that. We've got good data, the data that we've presented for our college journal quite recently, and other data that says if you explain things well and you craft the course of treatment, then patients, Indigenous, non-Indigenous, whatever background, if you make the effort to explain it, they will have the standard treatment and stay for the course.
How important is it to have Aboriginal staff involved?
Absolutely vital. Up here, Barb and her team are great. There's challenges that they face because it's not, we talk about Indigenous patients, but there's so many areas. There's obviously communities around Darwin, but Tennant Creek, Catherine. We increasingly are trying to treat more people from the top end of Western Australia. Each of those communities, there's language differences, there's trust differences, there's a different elder structure. So our staff, Barb, I keep saying Barb is amazing at being able to breach that. So and to get communities from wherever the patient is involved.
Can you just tell me, Barb, a little bit more about Barb? Who is she and what's her job, just in a nutshell?
Yeah, Barb's the Aboriginal, the Indigenous Liaison Officer, and I think that different centres, and Royal Adelaide obviously has a team of Indigenous Liaison Officers, and I think that up here, one of the important things is to have somebody that's in the centre who is absolutely a trusted member of the Indigenous community. So it's not Michael from Adelaide saying, well, you need to have that treatment. It's somebody that's sort of got that trust, and also who knows people who knows people who knows people, so that if there's, I don't know if I want that treatment. Barb's got great contacts in terms of, I'll get so-and-so to have a chat or whatever. And really, I suppose Barb's got a good network and she's trusted.
Thank you so much, Michael, for talking to us. Thank you.
No worries. Thanks, Julie. Good.
Well, it's my great pleasure now to welcome Giam. Hello, Giam. Can you introduce yourself and explain what you do at the Walker Cancer Centre?
My name is Giam. I'm the Clinical Executive Director at the Walker Cancer Centre for Radiation. So my background is from Adelaide with radiation oncology as a radiation therapist, but currently I'm managing the radiation oncology unit.
What are you doing that you're most proud of to try and change what you've just told me, so that people are diagnosed early, get the treatment they need, more of a chance of living and recovering, and also prevention? What are you doing there at Walker and in that community you're proud of?
I think when the Cancer Centre first set up, obviously we were a bit green behind the ears in terms of engaging with Aboriginal people, but with a lot of cultural training and also with learning, we managed to infiltrate the trust. The key word is trust, and trust from Aboriginal communities is the key in how to start engaging with any of the practitioners or any of the community elders group. So gaining that trust and having a reputation to be able to implement collaboration strategies is the key. So we started engaging with many health practitioners in the community. So we started a couple of training programs, which is a Cert 4 training program in cancer care. And in terms of delivering cancer care, there's no one better than the primary care providers. So we had a program where we can upskill and provide the knowledge for primary care workers or clinicians or practitioners to able to identify, detect early, to able to care for the patients while they're having treatment, to care for them while they're returning from treatment. And the most important thing about that training is to create a network. We need to have the direct network. That means they can access us directly without going through an intermediary source or another health jurisdiction.
So you're trying to avoid that desperate dilemma of delay that can be so deadly in cancer.
And if you look at the optimal care pathways, sometimes the delay is caused by so many factors, and many of those factors are not clinical factors. They could be family factors, they could be community factors, they could be, even logistics or even, referrals. Some patients just get lost because somebody forgot to follow up an appointment. So most of the communities in Northern Territory, we have got ambassadors, what we call people who we train. So they could be either chronic disease care coordinators, Aboriginal health practitioners, or even community Aboriginal workers. So we got people who we can contact if we're sending somebody back to the community. So what we do currently is all our head and neck patients have got a comprehensive handover to the community team. Because, for example, a patient goes home and some clinical centers do not dispense certain type of opioids or even soluble Panadol or certain creams, or even the dietary requirements are not there. So different community centers have got different facilities and different resources.
You believe that we need an Aboriginal cancer unit. Just very briefly, if you would, what do you mean by that and why do we need one?
The key thing I was saying earlier about trying to get an Aboriginal cancer unit is to be able to facilitate from primary care to acute care and back. An Aboriginal person from the community would like to have the same face and the same person or the same unit to communicate with, rather than, oh, I'm so afraid to see the next person, or I don't know what question, and you're not comfortable and you're not, unable to relate and engage with people. And we have interpreters, and interpreters play a key role. And every facet of care is done by various different personnel. So somebody to coordinate, or a unit to coordinate all those different providers of care is the key to providing comprehensive care for Aboriginal people.
I hope we both live long enough to see an Aboriginal cancer unit in Darwin. Giam, thank you so much for talking to us and giving us this time. We really appreciate it.
You're welcome.